Okay, Assalamu alaikum. Good evening or good afternoon, where everybody is. 8:30 p.m. in Jeddah, Saudi, and it's my pleasure. I have an excellent panel for you, the operator from Riyadh, and Dr. Hussam Noor, who's the Cto Operator in Defense Bahrain, and they will introduce our two speakers, and I will leave you Dr. Khalid. Khalid, would you like to introduce our first speaker?
Yes, welcome everybody to our video seminar organized by the GIS. I'd like to introduce our guest from South Germany, from Carlsbad, Germany. He's an interventional cardiologist, Dr. Erwin Blessing, who does a lot of peripheral CTOs, and leave the podium for him to speak to us about his experience.
Yeah, so a warm welcome also from my side. So it's a great pleasure for me to be part of that very exciting event here in the difficult times of COVID-19. So I'm by training a cardiologist and an angiologist, but I do, I'd say 80% peripheral procedures these days. So these are my potential points of interest. So when it comes to CTO, obviously these are the difficult of the difficult cases. So you want to have a game plan, you want to be well prepared. So you want to have as much information as possible up front before you start your intervention. So it's very important to know, are you dealing with an acute or a chronic ischemia? Is it a claudicant or is it a CLI patient? Obviously in a CLI patient, you can go even more aggressive because there is a potential of a limb threatening situation for the patient. So comorbidities also, you always have your open vascular surgery as an option. So are there comorbidities? It's very, very important. So in terms of pre-procedural imaging, I personally most of the time rely on duplex ultrasound. I always think it's very nice to have an MRI or a CT, but just because we're such a high volume center, I cannot guarantee having a MRI or a CT in all of those cases. So often enough, I honestly do rely on duplex ultrasound. But if you do have access to MRI or CT, it's always a good thing to get that because it makes it easier to come up with a game plan. When it comes to the pre-procedure game plan, obviously you want to have a good plan, whether it's the best access site to start ipsilateral, contralateral, whether you want to go retrograde, whether you want to start antegrade, do you go cross transperial or transbrachial. So that's very, very crucial. So be prepared. You want to have the entire armamentarium on your shelf to be prepared if you do run into issues in terms of perforation. You want to have covered stents available. You want to have the right sheath size that allows you all those options when things get tough. Adequate wire joint, support catheter, re-entry device, debulking device, if available. So in terms of access, vascular access is very crucial. And in peripheral intervention, basically there's the integrated approach where you have the pros as follows. It's a superior handling of wires, especially if you're dealing with bended iliac arteries. You do have a better pushability of catheter devices that makes it so much easier, in particular in below the knee interventions. You do have a select approach to the SFA and you save quite some contrast as opposed if you go crossover. On the other hand, the crossover approach obviously also comes with a number of advantages and the pros. It's always easier to puncture. The integrate approach does come with a certain learning curve. The crossover, the retrograde approach, crossover approach is also safe in obese patients. And we all know that patients are getting more and more obese. It also works in flush of occlusion in the SFA where you don't have a nice little entry, an entry into the SFA, where you just have a no entering zone into the SFA. Also, crossover approach often is easier to combine with retrograde puncture in terms of how you position your patient. It also obviously enables treatment of inflow lesions in the same setting. When it comes to wire passage, obviously you can go intraluminal, you can go subintimal. What's the pro for intraluminal? It doesn't take any further adjunctive treatment options out of your hands. You can still do the bulking technologies such as atherectomy, thrombectomy. On the other hand, often enough, even if you were trying very hard, often it's impossible to stay within the lumen in chronic total occlusions, in particular in the presence of heavy calcification. The pro of the subintimal, it also enables recanalization of very long chronic total occlusions, where again, often enough, you don't even have the choice to stick within this intraluminal space. And then the con, on the other hand, it takes off some of those debulking options where it's at least off-label for most of the devices. Higher stent use comes with a subintimal recanalization, and there's a need for devices in 10 to 15% of the cases. So to start with the basics, most lesions, if they are short, if they're not like very, very old, chronically totally occluded, often enough you can stay within the luminal space. That makes things so much easier. But then often enough, and now we are talking about more advanced approaches for CTO, you have a failure of the antegrade intraluminal vital passage. So what are the options? Obviously, first thing is you go subintimal. So what's the concept behind subintimal? That was described by Dr. Bolia in the late 80s. Obviously, if you start with the subintimal space over here, often enough, it's rather easy with a short loop to pass that occlusion, and then past the occlusion, the challenging part is obvious to re-enter into the intraluminal space. So that's the initials. If you want to get into the subintimal space, it's a rather easy thing to do so. And you can use a number of different approaches, angled catheters, different kind of wires. But to get into the subintimal space, I would say that's rather easy. So then obviously you try to cross the lesion and you pass the occlusion, and the challenging part obviously is then to get back into the intraluminal space. So at one part or another, at one point you might have to consider going either retrograde or using a re-entry devices. So let me spend just 1 minute or so regarding the use of re-entry devices. I know it's not available in all of those countries, and it does come at a certain cost. These are the usual suspects of the re-entry devices: the Pioneer Plus, the Entier, the Outback, the Off-Road. A just new kid on the block is go-back catheter, but I have to say I have my vast experience with the off-road catheter. And there's quite some also background from the literature that it's safe and easy to use if you do have access to a re-entry device. If you don't have access, or if the cost of the re-entry device do play a role, obviously now we move into the retrograde access. And obviously the retrograde access can be achieved via the transpedal, transpopliteal, or the distal SFA access. They're the so-called Safari and the CART technology, and you also be aware of those terms if you have a cardiology CT, because it's pretty much the same terms and the same devices used there and the approach. And you can come with a combination of the above. But let me first spend a couple of minutes regarding the retrograde access. So what does Safari mean? It means you create a connection between an antegrade and a retrograde subintimally placed guide wires to create a so-called flossing wire. And then you can externalize the wire and you can finish your procedure via the antegrade access. There's the CART technique, inflating a balloon over the retrograde guide wire, followed by advancement of the antegrade guide wire into the distal true lumen. Obviously, there's also the reverse card where you can inflate a balloon over the antegrade guide wire, followed by advancement of the retrograde guide wire into the proximal true lumen. So what about the clinical data? And there's just a rather recent substantial publication from the Leipzig group from André Schmidt. And he did nothing but 554 consecutive cases of infrainguinal occlusions with a failed antegrade approach. And we're not talking about CLI patients in 100% of those cases. Look at that. So there's almost 1/3 of those patients being claudicants. When we split up into the different territories, the FEMPOP segment was used in 36% of these cases, where the occlusion was in the FEMPOP segment, infrapopliteal segment 42, and both segments were affected, diseased, occluded in a little more than 20% of those cases. So if it comes to technical success, I mean, that's one of the most experienced interventionalists in the world. In his hands, he has a technical success in terms of achieving retrograde access in 98.6% of those cases. The successful lesion crossing and adjunctive therapy was successful in 95.1% of those cases, with a very, very low complication rate associated to the distal access. So it's very, very effective and safe in experienced hands. The freedom from TLR at 1 year was not necessarily determined by the operator, but also by the patient characteristics, baseline characteristics, comorbidities, and so forth. But it does seem to make sense also in terms of patency with the freedom from TLR in 3/4 of those cases. So let me introduce you my setup, how I approach a patient where I decide to go retrograde. I'm not saying it's the right way to do so. It's just my setup. I use local anesthesia at a retrograde puncture site. I always puncture with a 21 gauge needle, being 4, 7, or 12 centimeter in length under angiographic guidance. I'm not doing it under ultrasound. I'm just saying that's the way I'm doing it. I always access with an 018 wire. My wire of choice is the command wire from Abbott or the V18 from Boston Scientific. I, in almost all the cases, go sheathless with an insertion of an 018 support catheter, and I try to passage with the wire retrogradely through the occlusion using the reverse card technology. I always go for wire externalization, and I try to complete the adjunctive therapy via the antegrade access to avoid placing a distal sheath. So hemostasis, I, in all the cases, achieve either with manual compression and or balloon inflation from the inside artery. So this I want to share this CTO of the proximal anterior tibial artery. There's the distal reconstitution in the arteria dorsalis pedis. And we did fail with a antegrade approach. So I just want to share those few images. This is a access with a 018 wire over 21 gauge needle, as you can see over here. Then there is the next step. So it's basically 6 steps. The second step is then I do support my wire with a support catheter, again, not placing a distal sheath. Then often it's so easy to pass through that occlusion coming from retrograde, has to do with the fibrous cap formation, as you all are aware of. Then we always use the term snaring the wire, but we are not trying to destroy the wire. So in most of those cases, we're not using a dedicated snare, but we try to get it into a sheath from above. And now we advance a balloon or a support catheter again from above, and we do finish the procedure then via the antegrade access after we change the direction of the wire and we lead with the soft tip. So to make this story complete, this elderly lady with a CLI, I treated here. That's the final result. And this was the distal access of the arteria dorsalis pedis. So the title of the presentation is CTO from beginner to advanced. So I want to share just a couple of rather very special and very advanced cases. To start with the first example, there was an elderly lady, 87 years old, CLI patient on the right leg with the usual comorbidities, and obviously not a good candidate for open vascular surgery. So there is a total chronic occlusion of the popliteal artery here, as you can appreciate here. That's the distal runoff, a single vessel runoff via the peroneal artery, feeding the arteria dorsalis pedis here, very, very distally. And now, obviously, I always start with an antegrade approach from above, using a stiff catheter, 035 catheter, stiff Terumo wire, but then often enough you do fail getting into that distal re-entry artery, and you never want to make a long occlusion or long lesion out of a short occlusion. You don't want to dissect further south as absolutely necessary. So in that case, I decided to go for retrograde access. I punctured the peroneal artery. And then again, often it's still not so easy as it was in the first case I shared with you to cross that occlusion with all those techniques, with the safari, with the card and the reverse card. And you can see a balloon here inflated from the above, from the antegrade axis. You can see quite a distance between the retrograde wire and the balloon placed from antegrade. Now, in that case, I decided to go for a balloon, also coming from south, sheathless. In that case, you can see here the balloon inflation now placed from the retrograde axis. It still didn't work out quite as well as I was hoping. So I decided to go for the rendezvous, where we had two balloons placed, one from above, one from south, trying to break that membrane over here. And it still didn't work. So we had to move to the next step. And this is a combination of a retrograde access and a re-entry catheter I was just referring to. This is the outback catheter placed from above. And this is the Armada. It's an 018 low profile balloon used from retrograde. In that case, I did nothing but using the inflated balloon, just inflated very gently with 2 atmospheres as a target, so to speak, for the needle and the wire from the re-entry catheter from the outback coming from above. And you can see here, there is here now the successful puncture of the balloon with the needle from the outback catheter, and we kind of part now deep and bursted balloon, and we did externalize this wire now south outside of the patient, and that's just finishing up with a supera stent and a DCB, and that's the end of the procedure. So that was the initial puncture side. Again, just a gentle inflation from the inside and a blood pressure cuff. From the outside, 5 minutes, and you have a perfect hemostasis. So second and last case, this is now maybe one of the more extreme cases we did perform. There's the so-called Bresto technique. Bresto stands for precise retrograde implantation of a supera stent of the ostium. And that was even more challenging because in that case, the proximal 10 or so centimeters of the superficial femoral artery, they were surgically removed. This is the so-called profunda plastic over here. This is all prosthesis. This is the profunda over here. And the first 7, 8 or so centimeters of the original superficial femoral artery were surgically removed. So this is nothing but fibrotic tissue. This is nothing but scar formation in that artery. Now here, this is the so-called go-back catheter, again, inserted via the distal axis, sheathless here from below the knee. And then this is the supera after successful externalizing the wire. This is the so-called Bresto technique, where you precisely place that stent, again, sheathless from the below the knee area. And this is then the final result. Just a sec, this is the video running here. And I hope I can afterwards advance. And you can see on the right-hand side now the final image. We did it quite often, and a friend of mine, Lorenzo Patrone, he's an Italian radiologist working in the UK right now. And we did our series of, meanwhile, more than 40 cases where we used the outback reentry catheter in a retrograde fashion from either below the knee or from the distal SFA. And we had a technical success rate. This was just a preliminary analysis of 21 cases, but now 44 cases, and we still have a technical success rate of more than 95%. So, ladies and gentlemen, dear panelists and chairman, let me conclude. A proper pre-procedural planning, as always, is very crucial in those challenging cases. High technical success and low complication rates in CTOs comes with the subintimal recanalization technique. Re-entry devices, if available, also offer a very effective and quick way of re-entering if the standard technique is not successful in a subintimal approach. Then above everything I told you, I would really advocate the retrograde access. It really helps further to improve technical success rates. It comes with low cost. It has a very steep learning curve, and it comes with a very low complication rate. And for rather advanced users, the combination of retrograde access and re-entry devices, they offer additional options in very, very complex settings, as the last case I shared with you with a patient status post previous surgery. So that's the end of the presentation. Thank you very much for your attention.
Very much, Dr. Blessings, to the next guest.
You're welcome.
Sam, you speaker?
Yeah, can you hear me?
Yes,
Okay.
we can hear you. Go ahead.
Shall we go ahead with this next guest speaker?
Yes,
or
we
do you have any questions? Are there from
can
the?
hear you.
Are there any questions
Can
from the audience or the panel? Or
yes.
well,
Yes.
I have, sorry.
Questions are in the
okay.
Dr. Arwin, I have a question for you. What's your experience with the Avenger catheters, like the Ocelot or the it prevents you from doing that dissection reentry? It's OCT guided, and I think it's very useful. What's your experience in terms of those catheters?
Yes, I do have very limited experience with the Ocelot. As you mentioned, that's a dedicated let's say CTO device that allows you to stay within the intrahumeral space, and that avoids obviously things that are associated with subintimal recanalizations. Obviously, it does come with quite a cost. It's not available everywhere, but if you do have access to the device, I think it's a very, very sophisticated device. It does come with a certain complexity and cost. So I have to say, I'm not using it on a routine basis.
I see.
All right. I think we thank you very much. I think we'll move on to the other part, we were on the peripheral field. I think I have the privilege to introduce our colleague and the guest speaker, Dr. Laurent Dragul from France, Nice, France. And he will be enlightening us to talk about the management and recognition of complications during CTO. And there wouldn't be any more exciting than talking about complications. Dr. Laurent, it's our pleasure to having you on board. Thank you very much.
Doctor, you are on mute.
You're mute, Laurent.
Laurent, you can go ahead.
It's okay.
Yeah, great.
Thank you. Sorry for that. Is it okay?
Yeah, you're on fire.
Yes, thank you very much. Thank you to invite me to this presentation and to this nice meeting. So I will talk about the management of complication during Cto Pci. I will speak about coronary CTO. I hope it's not a mistake during the organization. You're okay with that? Not under the knee. So I don't have the time to speak of all complication we can have during Cto Pci. If you agree with me, I would like to speak during this presentation about perforation and about tamponade, because I think it's the worst complication we can have. Of course, we can have complication of the acute vessel closure, but we have to manage that the same way you use in normal angioplasty. I have not the time to speak about non-cardiac complication, so I will speak about perforation and dissection. So I want to speak to you about ELIS classification. I know you have a lot of kind of perforation for 3 tips, 1, 2, or 3. And when you have a 3 type perforation, you are in a bad situation with perforation into anatomic cavity, chamber, or coronary sinus. Type 1 is the one. Yes?
I think we need, if you could kindly share your slides. We don't see your slides, Laurent.
Oh, sorry.
Share your screen, please.
I share, but...
Dr. Lauren, yes.
Yes, I will share.
Open the presentation, Doctor.
Yeah, he's
Okay.
working with, yeah,
Yes.
great.
Is
Thank
it
you.
okay for you?
Yeah, we can see the ELIS classification. Yeah.
Alright, sorry, just so I will speak about perforation and tamponade, and this is the ELIS classification, as I mentioned before. So the 3 type is the worst type you can have during your procedure. I will show you how to manage this. So on the left part of the slide, as you can see, what kind you can have. You can have a main vessel perforation or an end branch perforation. The management of these two complications is not the same, of course. So first, the treatment is to have a long inflation with a balloon. You can use cover stent, you can use microcatheter, and you can use pericardic puncture and in worse surgery. During a CTO procedure, you can see in this slide what can happen to you when we have perforation, and you can see that ELIS 3 occurs in a long time, and what you can see that when the ELIS classification is 1, a lot of operators use only anticoagulation reversal and then wait. When you have to wait ELIS 3 type, you have a lot of tamponade. So what the first reflex you have to use when you have a perforation is to inflate immediately a balloon. and it closes the perforation, and you have to wait. And you have to wait a long, very long time. As you can see in this slide, you have a lot of complications, type 1, 2, 3 from Ellis, and they have used the long ballooning inflation. And one you can see for type 1 and 3, the during inflation balloon is more often more than 30 minutes. So you have to wait a long time to treat a perforation just with balloon. As you can see on this slide, you have during this procedure a distal perforation. So first reflex is to inflate a balloon. And to manage that, you have to use coil and use a microcatheter. So what very important thing is to very know your device, and you have to use microcatheter to use coil, but with an internal lumen more than 0.014, because if you use not the good microcatheter, you have to change, and so you must use coils we can use with a very small microcatheter. And in my practice, I use Terimo 1, or you have the Concerto from Medtronic. With this microcatheter, you can use this coil with all microcatheter you can use in situ procedure. So for me, it's very important, and you don't have the time to change the microcatheter during situ procedure to treat this. So in this case, one mistake was made, because you can see on the right part of the video that the first coil was delivered too far inside the artery, so there is no effect. So we have to put, and after that, you can see the perforation was treated with success. So first coil with the coil from Medtronic, which is
Did we lose Dr. Dragul?
Yeah, I can't hear him or see his slide.
I think we lost him. Shall we go ahead with? Yeah, we lost Dr. Dragul. Shall we go with Badr's presentation until he comes back? I think we should, instead of just waiting.
Just a comment,
So,
Dr. about the distal wire perforation. The take-home message here: you have to be careful about polymer jacketed wires and also hydrophilic wires when you do those procedures, and you want to make sure that distal wire doesn't go all the way in. So that's why you have to you want to use benign wires rather than polymer jacketed wires in those cases. So to just avoid such a perforation or so.
but these will happen.
Well,
True.
But it just, as we've seen, all of us have fear of complications, and especially perforations. When they have surveyed interventional cardiologists who do these CTO procedures, and they ask, what is the most common thing that you fear during CTO procedures? The answer was perforations. So I think having to recognize perforations and how to manage them is essentially very important.
Yeah.
The other thing I'd like to share with my colleagues and audience, is the algorithmic thinking. When you have a perforation, always think immediately, block and deliver. So whether epicardial perforation, whether a septal perforation, or whatever perforation, or main vessel perforation, the thing that when you have a perforation, the first thing that comes to your mind should be block and deliver. So if you have that acronym or that thing in your mind, it would save you, and then you can wait a little bit and think till you do something, and try to save the situation. I think we have Laurent back.
Yeah, so that. So I leave you. You have the screen, and the sound is good.
Yeah.
Okay, sorry for that. So as you can see, we go for retrograde in this case, and we have a very difficult entry point to the guiding catheter, and we start to treat this artery by antegrade. And as you can see, we use this epicardial, and we have first perforation on the epicardial from the circ with directly a big tamponade, and the first mistake was done in this case because we retrieve the wire and the microcatheter before control everything. So you never retrieve your wire and your microcatheter when you use a collateral before control that there is no perforation or rupture, because if you have perforation, you can use the microcatheter to deliver coils. So as you can see here, we have another thing. It's a rupture of the main artery of the right coronary. So we have double complication. One rupture on the right coronary artery and one perforation of the epicardial branch. So first, we inflate a balloon on the circ to close the epicardial branch. We can, of course, put a stent to close the epicardial branch, and we put cover stent on the right coronary artery. So I want to show you this case because we have made a big mistake to retrieve the microcatheter retrograde before control everything. As you can see, the 6 months control and everything was good, and you can see for the left. So I will just talk about 2 minutes about the management of pericardial draining. It's like rotablator. I think every time too late. You must drain the pericard very early when you see a perforation. You have to wait to reverse heparin. You must reverse heparin just after.
I think we lost him again.
Yeah, we lost him again.
I'm
Although
here.
I see. Okay.
You see my screen?
Yeah, we
Yes.
do.
So we make the local anesthesia. And as you can see, I use a wire and control that with injection inside for bubble directly inside the sheet I put in the pericard. You can see bubble showing that we are in good position. Introduce a long sheet inside the pericard after you are sure in good position, after you can drain the pericard. I use a long pigtail and put something. So if you have a big perforation, you can use the ping pong technique. In this case, we go for antegrade for a CTO of the right coronary artery. And we can cross antegrade the CTO segment, but after inflate and put the first stent, you have a big, we can see, sorry, you can see that we have a big perforation on the right coronary artery. So first, you have to inflate a balloon, like I show you on the first cases, and you have the time to wait. After, we have to drain the pericard and put a cover stent. But with the first cover stent, it was too small. And as you can see here, we have again a big perforation. So we have to put a second stent, but you don't have time to put first balloon, stent, extra. So you have to use 2 guiding catheter. One is used to inflate a balloon, and second one is used to deliver a cover stent. You can wait to exchange catheter or balloon. So it's a ping pong technique, very useful when you have a very, very big perforation and no time to deliver your stents. Very useful is to use an extraction of guiding catheter because it can close a little bit the flow inside the artery. And after that, on the right part of the angio, you can see the result of the right coronary artery. I use, you have a lot of cover stands. In my practice, I use papyrus cover stands, and you can use big graph coronary from Bentley. Very useful because you can use this cover stand in the 5 French. So it's useful if for people who use 5 French for angioplasty. And when you use cover stand, you have to know that you have, of course, instant stenosis at follow-up or stent thrombosis. I will conclude my presentation, and sorry for all problem with internet connection and with my dog. Donc, in our case, perforation are one part of the interventional cardiologist life. You have to well know all your device. For me, the most important is to use coils who can go through all microcatheter. You and your team must know where are the device in CAD lab because you have no time to look for coils or to look for cover stand. They must be close to you. So thank you for listening to me.
Thank you very much.
Thank you, Laurent. Thank you very much. It's really, you went to and touched the most difficult part doing CT procedures. And of course, you know, the coiling and beads or fat embolization is one way to deal or seal, especially distal perforation or epicardial or even septal perforators. But one comment that I have is when we talk about inflating balloon for a long period of time, and it does work, I do agree with you, but it also depends on the location of the perforation. So if you have an epicardial AV circ going to the RCA and you perforate it, you're probably going to balloon that, but you have to have a definitive treatment because these ones they don't have much of pulsatility and actually would bleed on you later on. So you may use a cover stent to occlude it or put a coiling. So these things we need to know and understand where is the perforation before we have the definitive treatment for them. What do you think, Laurent?
I think yes. In my practice, every time the balloon you use to close the artery is too small. So you have to use a big balloon to, it's the same with cover stent. You have to use big size of cover and stent because if you use smallest cover stent, it's not useful and you have blood outside the artery. But I'm totally agree with you for that.
I have a question for Laurent and the panel. Can you hear me?
Yeah.
Yes.
So what coil, we all have papyrus stents in our shelves and we all know where they are, the covered stents. But what about coils? Not all cath labs keep coils with them. So what coils are you keeping with you in your cath lab and not having to run to radiology?
In my cath lab, I use this from Medtronic. The name is Evo 3. I show you the slide. And with this coil, you are sure to use with all microcatheters. So from Medtronic, EV3. And when I do proctoring CTO, my first thing I do when I came to a new cath lab, I want to know where are coils. Because if you don't have this, it can be very, very bad situation without coils.
Waqar, I mean, we have one type of coils. I use the Axiom coils, and I specifically use the Axiom coils because it's 0.014 microcatheter compatible. I don't want to change that in terms of when we are in dire straits at that time. I also have experience with beads, but I kind of like coils more than the beads because beads could potentially be very irritant to the myocardium when you coil. It's very extremely painful. So I shied away from the beads. Now I have the Axiom coils.
Which size? Which size do you keep with you?
That's a very, very, very interesting question. And if you ask, we may have different answers to that. So it depends. I typically use the coils for epicardials, perforations, or distal perforators. And I look at the vessel. I mean, if it's I basically multiply the vessel size twice. If it is a 1 millimeter, I put a 2 millimeter. If it's a 2 millimeter, I put a 4 millimeter with a length of 10 to 20 millimeter. And I may use one or two depending on how it looks like. How about the other colleagues or in the panel?
Same for me, actually. We use Axiom, but unfortunately, it's not available in our lab. So before every CTO case, I go to interventional radiology in anticipation that I might have a complication. But luckily, so far, since I came back from Canada, I haven't used any coils, no perforations.
Yeah. And
but I think one of the most important things to say is the 3 pillars of complication: prevention, recognition, because often you miss a perforation if you didn't really focus into that angiogram and you didn't film long enough to see the perforation, especially if it's a distal, and then treatment, if, which you discussed nicely.
Laurent, how do you size your coils, Laurent?
So I use 2 millimeter by 4, 2 millimeter by 6, and 2 millimeter by 8. I start with the smallest, and if it's not useful, I use 2, 4, 6, 8, and to close the artery. One thing, if you use Medtronic coils, you have 2 ways to deliver the coil. You can break at the distal part of the coils and you deliver the coil, and you have a device we can use to deliver the coil. 2 ways to deliver the coil with Medtronic. There is a special device, I don't know the name exactly, but if you don't have this device, you can just break the coil at the distal part and you deliver the coil with this. You have to know that.
You're talking about the detacher, the coil detacher.
Yeah.
One, maybe Waqar, if you may allow me, and I've seen that in practice. I mean, this one area in which is common, it's like doing a TVAR or EVAR procedure. When you put the cover stents, and as my colleague Laurent just said very adequately, I mean, you think you have, sealed the perforation, and sometimes you have what is an equivalent to endoleaks. So if you have not really a positive vessel proximal to the perforation, you may actually develop tamponade in 24 hours, even though you have put a cover stent, because you have not expanded it enough, and it may leak between the coil itself, between the cover stent and the wall. So in my practice, I mean, I use quite often the ultrasound quite a bit. So if I have everything is stable, I'll take an extra 10-15 minutes and do an IVIS intravascular ultrasound, make sure that they really had a good seal, especially in the proximal and distal edges of the cover stent.
And because I have no time and because of poor internet connection, I would like to insist about when you do retrograde, you must inject for the donor vessel and to the retrograde vessel, and to show where is the perforation, because it's sometimes when you use epicardial or a septal branch where we have perforation, you have to coil through the antegrade vessel and through the retrograde vessel to close totally your epicardial perforation. So I don't have time to explain that very true, but you have to control antegrade and retrograde before leave everything.
No.
Excellent.
Shall we go for the case?
Yeah, fire up.
Okay, so I would like to introduce Dr. Badr al-Zahrani from Prince Sultan Cardiac Center from the Military Hospital in Riyadh to present a case. Okay, Badr. You have to unmute yourself.
Just one second. I'm just trying to find the slides. Just give me 1 second. I can share a screen. Okay. So it's really a pleasure to be here. I want to thank Dr. Waqar for the kind invitation. I picked a CTO case. Hopefully you guys like it. I want to thank also the whole organizing committee. So this is a case of CTO, and it's kind of going to give us a lot of learning points in terms of CTO and all the data that we're discussing about CTO, opening up CTOs compared with optimal medical therapy, and I want to show a case that CTO PCI does make changes in some certain cases compared to optimal medical therapy. So we have so this is my title is CTO opening the vessel to a normal lifestyle. So the story is this is a 45 years old gentleman with a history of diabetes for 10 years, hyperlipidemia, and he's a very heavy smoker. He's from the northern province of Saudi Arabia, and he developed progressive shortness of breath and chest pain, and he crossed the border and he went to Jordan, and he had all his cardiac workup done in Jordan. And they found that he had an ejection fraction of 20 to 25%, and that's consistent with our echo finding too. He had a hypokinetic mid to distal anterior wall, anterior septum, and anterior lateral wall with moderate functional MR. So he had the cath done in Jordan. You could see this is an AP cranial view that the LAD is occluded in the proximal portion. The circ is kind of diffusely diseased in the distal portion, and ambiguous cab, you can see exactly where's the LAD, and there is collaterals filling from the left to left collaterals filling that distal LAD there. This is another cranial shot. You could see the LAD is occluded 100%, and it's a possible codominant system, but you could see the left main is patent. This is a caudal view. The circ has diffuse disease, and you could see left to left collaterals filling that LAD. And this is a spider view. You could see the LAD is occluded in the proximal portion, and the circ, as we mentioned, is heavily calcified and diffusely diseased distally. RCA, 100% occluded in the proximal portion. There is collaterals filling from right to left. You can see that collaterals from the acute marginal branch filling that LAD, and the LAD is diffusely diseased. So they attempted a CTO at that time when they did the diagnostic. Obviously, looks like it's a Judkins guide catheter. Obviously, probably a stiff wires here. It's radiopaque all the way. They tried to attempt to open that LAD. I don't agree with using Judkins, obviously, in a CTO LAD like this. But so they tried to attempt this. This is just preview some more pictures. Looks like a floppy wire. So anyways, they failed that CTO, and he crossed, and he came to Riyadh actually, and he presented to an advanced cardiac center, and they had a hard team discussion about his case, and he was considered not a candidate for CABG or PCI, and he was evaluated for cardiac replacement therapy, LVAD, or transplant. And he presented to me in Prince Sultan Cardiac Center for a second opinion. So I just want to, I'm really interested to know from the audience and the panel, from the panelists and the chairman, Dr. Waqar, what do you guys think now? So he's coming to you, he's definitely symptomatic. He has NYHA class 3 symptoms, and he has angina class 3, and he's in optimum medical therapy, and you saw his angios. So what would you do?
If I might start first.
Sure.
Obviously, he's a young patient. He is very much impaired in his quality of life. He has a dramatically reduced ejection fraction, and that's all on optimal medical therapy. So there are two options. You go for the CTO if you have the technical capabilities of doing so. But my question would have been, why, if you do not have experience with the CTO, or if you fail with the CTO, why was he not a candidate for a CABG?
Well, actually, the discussion that the report that came from the other center, that he was not considered for CABG because of poor targets, is just diffusely disease.
Okay.
So the surgeon said, you know, no, he's not going to be a good candidate for CABG. That's the reason.
Okay.
Badr, I have a question from Dr. Abdullah Shihab.
Sure.
His question is mainly towards your indication. He says, what evidence is there to open this artery with PCI with low EF? He says, there is evidence for CABG, but not for PCI. Go ahead.
I mean, I think you're talking about someone who has an ejection fraction of 25%, correct? and it's obviously ischemic cardiomyopathy, rejection 25%. So, and nobody wants to operate on him. They have good surgeons at cardiac center. So the only option that this guy has is percutaneous revascularization, and considering CTO PCI. I mean, I know that the data doesn't support a lot of CTO PCIs, but that's why I'm presenting this case, is just to talk about this poor guy who's really young in his age. He's 45 years old, and he's really, really symptomatic, aggressive medical therapy. So I think I'm not going to leave him alone, honestly. So that's why we're going to consider revascularization.
Waqar.
Yep.
If I just also add to what Badr has said, as if this lesion was the type A lesion in his LAD, with my friend Abdullah Shah have the same question, we're just going to go ahead and fix it. We have to think about it that way. I mean, it's a matter of symptoms, like any other angioplasty that we do in our daily practice. If we can, with whatever material we have, to fix it, either surgically or percutaneously, to alleviate his symptoms, is number one before we're talking about mortality. So this gentleman is crippled with angina, so something has to be done. My comment as well to Badr is, and also to the audience and the attendees, this is not an easy CTO, you know. There are ways you can determine how difficult this case is. You know, you can use a JCTO score, the progress CTO score, and this is not for somebody who's starting the procedure, his experience in CTO procedure. So if you see what Badr has showed us, that use JL guide to do this complex CTO, no dual injection, no microcatheters that I saw, there's so many no. So there's no place for ad hoc CTO procedure, especially when you have a case like this. You don't live in an isolated island. This is a case that should be, if you can do it with good expertise, fair enough. And if you can't, then refer it to somebody who can do it. Thank you.
So
you're right.
I agree with you about the ad hoc CTO PCI, because I've been seeing people doing this. And actually, for the fellows and the people in the audience, we know that CTO is a high-risk PCI. And high-risk PCI CTO is a totally different consent than a regular PCI. And you have to explain to them about the risks and benefits about this procedure and what may happen. But an ad hoc, I would never do an ad hoc PCI and PCI CTO to anyone. Like I would wait and plan it and discuss it. But so yeah, you're absolutely right. I agree with you 100%.
Badr, I have about 7 questions online. They are all asking viability. They are asking, did you assess viability? Do you believe in viability?
Okay, so there is from the Stitch trial, correct, with CABG versus doing viability didn't make any difference, correct? So, and the other thing also, I looked at his echo myself. It's not a thinned out myocardium, it's hypokinetic, so it's a viable myocardium. So, and I think if it was thinned out, akinetic wall, possibly I would consider doing MRI, but I don't think that this is not supported by data, by the way. I don't think the data supports viability, honestly. And if someone is aware about any data that that viability is going to change anything, I would really be happy to know about it.
Yeah.
Any other questions?
There's one more question. Would you do a pre-CTO CT angiography? It's a question about CT angiography for planning.
Absolutely not. Absolutely not. And by the way, we had this discussion about CABG patients too. And we don't usually do routine CTs. I mean, we just do our diagnostic angio. You have to have good skills in terms of doing a good diagnostic angio with dual access and stuff like that if needed, and to plan your procedure very well. So it's all about planning, but I would never do a CT to guide my CTO for CTO PCI.
Waqar, may I,
Yes,
also
please. Go ahead.
contribute to what Badr has said? I mean,
yes, please.
In occasions you may need to, especially failed CTO procedures. And if I really have an osteoflash LAD, and sometimes you have separate LADs coming up like almost separate origins, and you think that left main to the circ, we maybe have a different trunk coming off of them. So, I mean, I wouldn't say never. I would say yes, it could help me occasionally, the CT, to find the course of the vessel and how much calcification, et cetera, et cetera. So CT as a modality is sometimes quite helpful, actually, in cases like this.
Yeah.
And IVUS too, but it depends about the it depends about how many slides the CT that you have, correct?
Right.
So if you're using a 64 slice CT is different than 360 and the advanced one. So it depends which center you're working in. So
I think in your center, better when you're doing advanced CTO procedures, I'm sure you have the advanced CT as well. So
correct.
I second Dr. Hassam about using CT. It's actually very helpful in to de-ambiguize the proximal cap in such cases like the case you have here. What I found it very useful and actually near routine to me is post-cabbage patient. When the surgeon insert a graft, they tend to tent the vessel. So to identify the course, having a CT scan is very helpful in post-cabbage patients.
and let me add to that too. There's also CT mandated scoring, which can tell you how difficult your potential CTO procedure is. So you have the JCTO score, you have the progress CTO score, I forgot the name, the CT related scoring. Also, you can use a CT to assess the complexity of your procedure. But as Badr said, you really have to have a high-end CT machine that can give you all this information.
Okay.
Let's move on, Badr, yeah.
Okay.
Okay.
So if you look at the JCTO score that we discussed about, he's scoring everything basically. So he has a blunt entry, he has a calcified vessel. You could add that bending also. It's definitely more than 20 millimeter occlusion, and it was attempted. So this guy is really scoring really high, making it very, very difficult CTO to open up. So we brought the patient. We got two axis actually. We got a right radial axis 6 French sheath, and I got a femoral axis a 6 French sheath. His iliacs were not tortuous, so I used the short sheath. Some people prefer using a long femoral sheaths for support, but I used the short one. His iliac was straightforward, but I used the 6 French. So this is a GR4 diagnostic angio, and you could see he has robust collaterals to the LAD from that acute marginal, and the RCA is occluded 100% in the proximal portion. So there is right to right collaterals and there is right to left collaterals too. So we got dual axis. This is a GR4 diagnostic catheter, and this is an EBU 375 engaging the left main. We did this dual axis. You could see the LAD is 100% occluded proximally. We did dual injection angios too. So we navigated the wire. I started with a floppy wire just to put the microcatheter in the proximal LAD first. This is a Fielder XT wire, so it went to first to a diagonal. So we then pulled back and navigated again. We did antegrade wire escalation, and actually this is a Corsair microcatheter. You could see the wire passing also into another diagonal, which is, it tells you that you're luminal most of the time. So we pulled back and then we navigated the wire, and you can see there is a small micro channel. So at this time, we switched the wires to the Fielder XT wire, and multiple manipulations, we're able to pass the wire to the distal LAD. I did a small contrast injection that confirmed that the microcatheter was in the distal LAD. Next, we put a floppy wire actually, and then we started balloon inflation with a 2015 balloon, and you could see the vessel is actually all diffusely diseased. And the mid LAD has some dissection there with the antegrade wire escalation and reentry. Next, we placed a 225 stent, I think by 22 or 23, if I remember, and then a 275 here, long stent. And then we actually stented, sorry, I'm missing some slides here. We stented also to the left main because the disease extended to the left main. 1 second. So I don't see the slide upper, but we stented to the left main. and we did pot using a 4.5 millimeter NC balloon, and then rewired and kissed. And this is the final shot we got. This procedure was done, I think, if I remember, just before the Corona era. And then he's supposed to follow up with me, and we did that through a virtual clinic. And his symptoms really improved to the degree he's not thinking also about opening up the RCA. So he's running like 4K per day. He's on full optimum medical therapy, but absolutely asymptomatic right now. I don't have a repeated echo because he didn't physically come to my clinic, but that's the plan in the soon future. He's in the northern province right now, so but he's planning to come to Riyadh and I'll repeat the echo and see what's the ejection fraction at that time. So I'm open to any questions from the audience or the panelists, and hopefully you guys like this case. I thought it's interesting and it changed the life of this young guy, and I'm so happy for him.
Thank you.
Thank you.
We will open for questions. Laurent, Hussam, Khalid, and Erwin, any questions for Badr?
Yep. Yes, I have comments. So congratulations, because this case was very, very difficult, and the result is perfect. And I'm sure that the ejection fraction is now minimum 40. So one question: when you are going to the second diagonal, at the moment you were in the true lumen, do you have think about using a double lumen micro catheter? So what is your opinion about micro catheter?
I think it's a very useful tool if you think that's because you're not going to lose the wire position that you have. But what I did is I knew that the vessel is really, really tiny. And I thought just with a Fielder XT, a little bit of a navigation, I'm going to get it. But you're absolutely right. I mean, the dual lumen catheters are very, very helpful, correct? Because you don't lose that position. You're safe. You could put another wire and use, you know. So, but I agree with you. I mean, you could use, what is it called? The micro catheter that has a dual lumen, and you don't lose one position. It's very helpful. I agree. I was able to navigate the wire to distal and confirm the wire position.
And a second comment, I'm very happy because you have used a big stent. And when you see the artery, we think it's 1 millimeter distal artery, and you have 2.5 stents without IVUS. And I think you have done the good choice, because we control all CTO at 3 and 6 months. And I'm sure this artery was a 2.5 or 3 millimeter artery. So what do you think about how do you choose your stent size in this case?
So there is a very interesting study that was done about normal coronary vessels, okay? And there is not even one single Prox LAD that's less than 3.5. And that really changed my practice when I read that paper, because I used to use EO stents a lot. Although there are some exceptions, by the way, in Saudi Arabia. But I use a lot of 3.5 stents when it comes to Prox LAD, and I use IVUS a lot, actually. And you're absolutely right. This is a CTO. This is underfilled vessel, and you want to give this guy the maximum optimum therapy for him. But we used the 3.5 stent in the Prox LAD, extending to the left main. We ballooned the left main stent with a 4.5, and I think but you're absolutely right. I would agree about imaging, absolutely.
One comment here, Badr. Congratulations on good results. It's a very tough case. It takes a lot of guts to do a complex CTO in a patient with that low EF without considering support. But it went well, and I think the key is what I would do differently is maybe distal LAD I would treat with drug-eluting balloon to massage the vessel, and hopefully that will grow and prevent me from putting a lot of stents. If it wasn't disease and there was no calcium or dissection limiting my choice of drug-eluting balloon. I know there is a lot of growing evidence now with drug-eluting balloon in small vessel, and they are comparable to stents if you don't have a limiting dissection. But overall, this is an excellent case. Good job.
I mean, I would really be interested to know about drug-coated balloon, because I mean the evidence is not really strong, and believe it or not, still didn't get an FDA approval in the States. So we never had drug-coated balloons in the States whatsoever, except for peripheral. But we had a lot of cases that we wish it was on the shelf, honestly.
We did have it in Canada. We used it mainly for ISR to prevent a second stent from placement. And we've used this also to massage. They call it massaging the vessel distally when you don't want to place a stent. And I have a few experience actually cases where it's actually as good as a stent. Yet you're right, there is no much RCTs, but there is some studies from Europe mainly and Germany that did show that it's a decent result.
Waqar.
Yes, go ahead.
Badr, thanks a million. It's really fantastic. And you know, you've touched on many aspects in this complex case in a few minutes, but there's a lot to learn from this. And one, as you correctly answered, imaging is, I think, is a must. Then the issue of negative remodeled vessels. And if you look at the, I mean, there's a randomized trial or a study by the guys from the UK, Simon Walsh and his group. They did the consistent CTO, and they looked into these patients had the option to come back and have a, you know, had the repeated angiogram, whether you need to do something more and see what happened to the vessels. Actually, 30% of the time they had to do more work to optimize the results. And as you know, as we all know, that the LAD is very, very important vessel. So a case like this, probably in my practice, I'll bring them back within 3 months. And you know, of course, now we may discuss about the finances and stuff like that, but I could bring them back in 3 months, see what happened to the vessel. I image them more and see if any I can optimize them. So that's one comment that I have. There are a few questions from our friends, and I think there's a lot of interest about hemodynamic support. Shall we do this case on hemodynamic support? Yes or no, and how you really. How do you decide you're going to do it on hemodynamic support or not? And which hemodynamic support do you use in a case like this?
So basically in a CTO cases, I'll be honest with you, rarely we use protection with protected PCI using an Impella or so, because the vessel is occluded 100% anyways. And if you pick the retrograde approach, I would probably consider hemodynamic support, because you have a lot of collaterals going from the RCA to the LAD. But going antegrade, I mean, the vessel is occluded 100%, and you do have left-to-left collaterals from the left system and from the RCA. But the RCA, if you look at the angios, there's a lot of collaterals coming from that acute marginal that's supplying that LAD. And to me, one of the things that I do, I pull the dual axis catheter. The other catheter, I take it immediately out whenever I have antegrade access, because I don't want a thrombus to happen in the other catheter or something. Of course, I'm going to check about ACTs, but once I get access, I take the other catheter out. But I would rarely use hemodynamic support for CTOs, honestly. And I'm really interested to know about from the panelists here. Do they usually do that, or it depends on case-to-case basis, or?
We usually do, because it can actually, because I know CTO is a stable CAD, but if a complication happen, if a thrombosis happen, if perf happen, these patients don't have reserve and they will collapse immediately. What I use before to decide is right heart cath and cardiac index. That always guide me and show me that yes, I'm going to need it or not. But definitely I will consider it, especially with this low EF, 20%. It's a scary EF, and it's walking in thin ice. And at any moment, if you had a dissection in the left main and you occluded the circ, it's a dominant circ, this patient will not come back.
Laurent, what do you do?
In this case?
Do you consider hemodynamic support?
No, I don't use. Because if you do this case, you have to do quickly and very quickly and without a lot of things to put. And in my practice, I think you just have, when you use hemodynamic support, it takes time to put everything, to retrieve everything. The patient can move after, and you must success, but very quickly. I don't use hemodynamic support. I have question about this case. In case of failure antegrade, this case was very, very difficult I don't see all the angio, but I think there is no way for retrograde approach, or very, very difficult, and no way for dissection reentry. So you have to success this case antegrade. What was your opinion in case of failure? What was your option?
Whoa, that's really a tough question. But if you see, I think if you see the acute margin, I mean, you could consider retrograde approach. Let me just go back. It's going to be a difficult one though, but it's a small vessel, and you're never going to do it without protection because you're going to be ischemic, and you're going to be occlusive too.
By the right coronary artery?
Yeah, I'll show you. So if you see this view, there is an acute marginal here that goes all the way, that fills the LAD distal. Okay, so I'm not sure if you could pick that, but
it's sure. An pericardial.
Yeah, so it's going to be a difficult case, honestly. But I think the only option in this case is integrate wide escalation, honestly. So.
Erwin, what do you do? I mean, the good question that Lauren had, you're doing antegrade wire escalation and you fail. I mean, you have a lot of experience in peripheral as well as CTOs. What would you consider here?
Well, honestly,
maybe I go for ADR, but you have to be very, very close to the main vessel for the ADR, because the distal part of the LAD is very, very small. So the re-entry will be very, very difficult. And for me, this epicardial from the right is terrible. So it's why this case is difficult for me, because you have very less option in case of failure with wire escalation.
So, I mean, a question to you guys also, would you find a surgeon who's going to operate on such cases?
Yes.
No. I don't think we'll find a surgeon to operate, not in our area.
The same, because of slow ejection fraction, and the LAD is too small. So they don't want to touch these patients. So
I think I mean, we have a surgeon that is very capable of doing it, to be honest with you. But Erwin, what do you think about this case? I mean, you did some crazy work in peripheral work, and I'm sure you have, what would you do?
Yes. In that case, I would do the same. I would go for an antegrade wire escalation, and if I fail, I don't have the experience doing such a complex retrograde case via the RCE. So I would stop there. I would discuss it in a heart team, and I do believe that I find a surgeon accepting that challenging surgery case. If I fail antegrade.
I mean, ADR is an option, but this is, I mean, this is an area which I would not recommend. I would not recommend injecting via the microcatheter after you cross the CTO, because if you're subintimal here and you're subintimal, I can just switch it to a Stingray balloon and try to reaccess distally. Once I do the injection through the microcatheter, I will extend the dissection, and it would be, my reentry would be extremely difficult. Just a comment.
Yeah, the only reason I did that is because it's such diffuse disease, and I'm not sure I'm interluminal, honestly. So there was some blood draw when I aspirated from the catheter. So I said, you know, so I'm just gonna give it a try, because if I ballooned it, and I may actually worsen the whole thing, correct? I mean, if it's subintimal the whole way, it's such a difficult case, honestly.
I mean, aspirating blood through the medallion syringe would not give you a guarantee that you are interluminal. You could still be subintimal. That's one. The other thing you can do, you just take a workhorse wire if it's going to the branches. That would tell you you've got access to the true lumen, like a sine wire. The third, of course, as we all discussed, that IVUS would tell you, where are you? Because if you inject through the microcatheter, it would limit your ability to re-enter if you're really subintimal. So the case is done. The case is done even now, because you're in the lumen, so you're fine. But if you're subintimal, the case is done because you can't finish the case. Yeah.
I think the best
any
thing,
more questions?
Yeah, there are.
Fire them up.
Well, one question is, without using IVUS, how did you decide the distal landing zone?
Well, it's based on the angio we took, honestly. We picked the best landing zone that we could pick. It's diffused with disease all over, honestly. So we started with the 225 stent distally, 275 ballooned with 3.0. This was such a very long procedure, by the way. So,
Yeah.
and we used a lot of
I can imagine.
contrast. So
I would, like Sam suggested, I have brought patients like this back, and alhamdulillah, you can bring this patient back, repeat cath with
Absolutely.
IVUS and optimize those stents.
Absolutely,
And
absolutely.
assess the EF.
And I'm pretty sure, based on what I heard from the guy, I'm pretty sure all these distal vessels are remodeled by now. Because
And
in
see what his
really
ejection fraction is.
therapy, his symptoms are really improving.
I have a question from Dr. Al-Tayyib Yusuf. Do we have surgeons who do endarterectomy anymore?
In our center, I don't think
We do have in our center, but the result is opaque. We don't know how long they can last.
Mm-hmm.
And I don't send patients for endarterectomy.
I would love to hear from a surgeon if we have a surgeon. And
No.
But what's the purpose of the question, Waqar? I mean,
I think the purpose would be, because it's diffuse disease, you would endarterectomize the entire vessel and then put the graft. That would be my answer for that.
I haven't followed the literature on that, but I think one time we had a debate that, especially LAD endarterectomy, they don't do very well. And I don't know, to be honest with you, compared to an extensive stenting and ballooning versus endarterectomy. I don't think there is a trial addressing that, but just looking at the surgical series in which they have done endarterectomy, the results are not that good.
Yes, that is correct.
But better you have more CTOs than this guy, right? I mean, you have an OM, a CTO that is blocked. You have a potential either left-sided PDA or what. So
he has disease everywhere. But I would be interested to bring him back.
Yeah, please.
After Hajj, we're going to bring him back and cath him again, and we'll see. We'll see what we find. But for sure, I'll consider the IVUS thing. It's because it was just such a long case, and took a lot of contrast at that time. So
very interesting.
Right. All right. I think we are almost till the end. Do we have any questions? Any other questions for all the speakers?
Just one question for me about the marginal branch.
Yes.
Do you consider to try to reopen this branch?
Would you try to open it even if patient is completely asymptomatic, Laurent?
That's really interesting. That's really interesting because he's absolutely asymptomatic now. But there's a lot of things you need to gather, correct? You need to bring him back. You want to do an echo. You want to evaluate his ejection fraction. You want to see, but what would you do like if his ejection fraction improved? I think possibly nothing. And probably optimize his stents with IVUS. And I think that's what I would do, and that's it. But other revascularization, I don't know. I mean, I would not do anything, honestly, with that left PDA.
Waqar, can I take that?
Yes, please.
I think you have invested heavily in this young man with extensive coronary disease. And I think even if he is asymptomatic, if you look at the Delta syntax score, would be more than 8 if you calculate it now. Still, with that OM, you have a PDA and the right occluded. And then this is a case, even if they're asymptomatic, if you do complete revasc, it is associated with improved survivor. So if this is an 80-year-old man, I would have said, fine, I'll wait. I wouldn't do it anymore because I'm just doing it for symptoms. But if I think he was in his 40s, a young man, that if we could potentially completely revascularize him, we could have better survival, didn't it?
And I absolutely, look, I'm one of those people who totally believes in complete revascularization. But we know about the complete trial in ACS when they did complete revascularization. And one of the things you achieve actually by doing a cabbage is complete revascularization. But this guy, you have to gather all the information together, bring him back, see what's his ejection fraction, see what's his anatomy again when you cath him, but and see what you're gonna do. But and then decide. But I agree with you. I'm a big believer about complete revascularization. Absolutely.
Dr. Waqar, one last comment about the complication lecture for Laurent. About the reversal of heparin. I actually disagree most of the time to give an antidote in any, because actually it might make things worse. If you have a thrombosis, then you have two problems.
Yes.
I think solving it with balloon inflation or coils would be more appropriate than reversal, because because we did have a lot of perfs during my fellowships, and we never reverse, never, almost zero.
I
What do you think
totally agree
about
with you. I reverse heparin only when I have drained the pericard totally. So you drain your pericard when there is nothing on echo. You can reverse heparin, but half dose, not totally dose. But in some cases, it's not useful. I agree with you. You don't reverse heparin, but in some cases you have to because there is no way. But just after drain the pericard.
And you have to train.
All right.
You're absolutely right about just one more thing, Dr. Waqa. In terms of the pericardiocentesis, I always recommend doing a subxiphoidal approach, because you want to really master that approach rather than doing apical and subxiphoidal. So whenever you have the both ways to do it, you want to do a lot of subxiphoidal, because those emergency cases, you don't have that much time, correct? I mean, you need to do it really quick. So you have to master subxiphoidal approach in terms of pericardiocentesis.
All right. I would like to close this session. I'd like to thank the Gulf Intervention Society for putting it together, for our speakers, Laurent Dragul and Irvin Blessing, and our excellent panelists, Hussam Noor, Khalid Al-Juhani, and Badr Zahrani for being present, and all of you who attended this. And I hope the take-home message is that cardiologists can do peripheral interventions. And if you're going to do CTOs, you better be prepared for complications. Complications are part and parcel of CTOs. So you cannot say I do CTOs and I have no complications. Complications. From Dr. Objection Frack, and I would like to thank all of you and hopefully to be khair. Thank you.
Thank you very much.
Good to be here. Thank you.
Thank you, guys.
Thank you so much.